Your liver is one of the only organs in your body that can regrow itself. Surgeons can remove more than half of it for a living donor transplant, and within weeks it grows back to nearly its original size. That same regenerative power is exactly why liver damage can stay completely silent for years before you ever feel it. Before we get into the test itself, it helps to know what this organ is actually doing for you around the clock. It filters toxins out of your blood, manufactures the proteins that carry things through your bloodstream, produces the bile that helps you digest fat, and stores extra energy and vitamins for when you need them. Here's something worth knowing up front. Liver function tests is actually a bit of a misnomer. Most of the markers on this panel are alarm bells for liver cell damage, not direct measurements of how well your liver is working. So what actually happens when you get this test done? A single blood draw gets sent to a lab, where technicians measure the levels of several different substances, some enzymes that leak out when liver cells are stressed, some pigments your liver processes, and a couple of proteins your liver actually manufactures. Here's a rough guide to what normal usually looks like, though every lab sets its own ranges, so always compare your results to the numbers printed on your own report. ALT and AST typically run under about 40 to 56, alkaline phosphatase under about 120 to 147, and total bilirubin under about 1.2. Doctors order this panel in a few different situations, and the reason matters for how the results get interpreted. It might be a routine screening at an annual physical, a workup for symptoms like fatigue or yellowing skin, monitoring for a medication known to affect the liver, or a check before starting a new prescription. Let's meet the individual markers, starting with the two that act like alarm bells. Keep this in mind as we go. This panel is mostly measuring signals of stress or injury, plus a couple of true output measurements. Knowing which is which changes how worried you should be about any single abnormal number. Think of ALT and AST as smoke detectors mounted inside your liver cells, not measurements of the fire itself. Both enzymes normally live inside liver cells, doing routine metabolic work. When those cells get damaged, whether from a virus, alcohol, a medication, or excess fat, the cell membrane becomes leaky and spills its contents into your bloodstream. That leak is exactly what a blood test is picking up. How high the number climbs roughly tracks how much cell damage is happening, though it doesn't tell you the cause on its own. Mildly elevated, under about twice the upper limit, is common and often reversible. Levels in the hundreds or thousands point to something more acute, like a severe drug reaction or a viral flare. ALT is considered the more liver-specific of the two, since it's found mostly in liver cells. AST shows up in liver cells too, but also in muscle and heart tissue, which is why an isolated AST rise doesn't automatically point to your liver. There's a genuinely useful pattern buried in these two numbers. When AST runs noticeably higher than ALT, roughly double or more, that combination is a classic signature of alcohol-related liver stress. When ALT runs higher than AST, that pattern points more toward fatty liver disease or viral hepatitis instead. Take a routine case. A 45-year-old with no symptoms gets an annual physical. ALT comes back at 68, AST at 40, everything else normal. No alcohol use, on no new medications, but he's carrying extra weight around his midsection. This mild ALT-predominant pattern is the single most common reason people get referred for a fatty liver workup. The encouraging part, this pattern is often reversible. In people who lose a meaningful amount of body weight or significantly cut back on alcohol, ALT levels commonly drop back toward normal within a few months, since the underlying stress on liver cells eases up. ALT and AST are damage alarms, not diagnoses on their own. The pattern between them, and the story around them, does most of the real work. If ALT and AST are smoke detectors, alkaline phosphatase and GGT are more like pressure gauges on your body's plumbing. Bile flows from your liver through a network of small ducts into your gallbladder and eventually into your intestine, where it helps digest fat. Alkaline phosphatase concentrates around those bile duct cells, so when something blocks the flow, like a gallstone, pressure builds up and ALP backs up into your bloodstream. Here's the catch with ALP on its own. It isn't unique to the liver. Bone tissue and, during pregnancy, the placenta both produce it too, so a high ALP alone is genuinely ambiguous. Growing teenagers commonly have naturally high ALP from active bone growth, with nothing wrong with their liver at all. That's where GGT earns its keep. GGT is produced almost exclusively by the liver and bile ducts, so pairing it with ALP resolves the ambiguity. High ALP with high GGT points to your liver or bile ducts, while high ALP with a normal GGT points you toward bone instead. A handful of situations commonly drive this plumbing pattern upward: gallstones blocking a duct, certain medications, a narrowed bile duct from inflammation or scarring, and, notably, heavy alcohol use, which raises GGT specifically even without full-blown liver damage. A 52-year-old woman comes in with sudden right upper abdomen pain after a fatty meal. ALP is elevated at 220, GGT elevated at 180, ALT and AST only mildly up. An ultrasound confirms gallstones sitting right at the duct opening. This is the textbook plumbing pattern. The blockage, not cell damage, is driving the numbers. One quick note before we move on to bilirubin. GGT can also rise slightly from certain seizure medications and even some herbal supplements, so a mild elevation on its own isn't automatically alarming. If this kind of practical detail is useful, subscribing helps more of it reach you. ALP alone is ambiguous. Bone or liver. Pair it with GGT, and you know which plumbing system is actually under pressure. That yellow tint you sometimes see in the eyes or skin during illness has a specific molecular cause, and it's one your liver processes every single day without you ever noticing. Here's the pathway. Your body constantly breaks down old red blood cells, and the pigment released from that process is bilirubin. Your liver grabs that raw bilirubin, chemically modifies it so it becomes water-soluble, and excretes it into bile, which eventually leaves your body and gives stool its normal brown color. Blood tests actually separate bilirubin into two forms, and which one is elevated tells you where in the pathway the problem sits. Indirect or unconjugated bilirubin is the raw, unprocessed form, elevated before the liver gets involved. Direct or conjugated bilirubin is the already processed form, elevated when the liver has done its job, but something downstream is blocking the exit. Total bilirubin usually needs to climb to roughly double or triple the upper limit of normal, somewhere around 2 to 3 milligrams per deciliter, before jaundice becomes visible to the eye. Below that, elevated bilirubin often shows up only on a blood test, with no visible symptoms at all. When bilirubin does climb high enough to notice, it shows up in a fairly predictable order. The whites of the eyes usually yellow first, since that tissue has a strong affinity for the pigment, followed by the skin, and, in more significant cases, darker urine and paler stool. Myth: any jaundice or high bilirubin means serious liver disease. Fact: roughly 5 to 10% of people carry a completely benign, inherited condition called Gilbert's syndrome, where bilirubin runs mildly high, especially during stress, fasting, or illness, with a perfectly healthy liver underneath. It's worth knowing this pattern isn't unique to adults, either. Newborn jaundice is extremely common in the first days of life, simply because a baby's liver hasn't fully matured yet at processing bilirubin, and it typically resolves on its own within a couple of weeks. Bilirubin tells a location story: indirect points before the liver, direct points after it. And a mildly elevated number, especially with an inherited condition like Gilbert's, isn't automatically a red flag. Of everything on this panel, albumin and clotting time are the two that actually measure what your liver is producing, not what it's leaking. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. Albumin is a protein your liver manufactures continuously, and it does a lot of quiet work. It keeps fluid from leaking out of your blood vessels into your tissues, and it acts as a delivery truck for hormones, medications, and other molecules that need to travel through your bloodstream. Because albumin production takes weeks to slow down after liver injury begins, a low albumin level is much more useful for spotting a long-standing, chronic problem than a sudden, acute one. A perfectly normal albumin doesn't rule out early liver stress. It just means production hasn't been impaired long enough yet to show up. In someone with worsening chronic liver disease over several years, you typically see albumin trend steadily downward, reflecting the liver's factory output gradually slowing, rather than any single sharp drop. The other true function marker is clotting time, usually reported as PT or INR. Your liver manufactures most of the clotting factors your blood needs to form a clot, So this test essentially measures how quickly your blood clots compared to a standard reference. A stretched-out clotting time is one of the clearer signs that liver production has been meaningfully affected. A meaningfully elevated INR in someone with known liver disease is taken seriously, since it signals the liver's manufacturing capacity has dropped enough to affect blood clotting itself, which is one of the clearer warning signs doctors watch for in more advanced liver disease. Quick aside, albumin and INR are also two of the main ingredients doctors use to calculate liver disease severity scores for things like transplant priority. If you're finding this useful, a like helps this kind of content reach more people. Albumin and clotting time are the real function gauges on this panel. They move slowly, but when they do move, they're telling you something meaningful about how well your liver's factory is actually running. Put all these markers together and two big picture patterns emerge, and recognizing which one you're looking at narrows the cause dramatically. A hepatocellular pattern means ALT and AST rise much more than ALP, pointing to direct cell damage. A cholestatic pattern means ALP and GGT rise much more than ALT and AST, pointing to blocked bile flow. So when a panel comes back abnormal, the first mental step is sorting it into one of these two buckets. From there, the hepatocellular bucket points toward causes like fatty liver, alcohol, viral hepatitis, or a medication reaction. The cholestatic bucket points toward gallstones, bile duct narrowing, or certain drugs that slow bile flow. Of all the possible causes, one now dominates the statistics in a way that surprises most people: fatty liver disease, recently renamed metabolic dysfunction-associated steatotic liver disease, is now estimated to affect close to 30% of adults worldwide, making it the single most common chronic liver condition on the planet. Fatty liver disease develops through a chain reaction tied closely to metabolic health. Excess calories and insulin resistance drive fat to accumulate inside liver cells. Over time, that stored fat can trigger inflammation, and in a meaningful subset of people, that inflammation progresses toward scarring. Beyond fatty liver, the other major contributors round out the list: heavy or long-term alcohol use, viral hepatitis A, B, and C, each spread differently and carrying different chronic risk, and a long list of medications, both prescription and over-the-counter, that can stress the liver in susceptible people. One medication deserves specific attention because it's so widely used and so easy to underestimate. Acetaminophen, sold as Tylenol and in countless combination cold and pain products, is the single leading cause of acute liver failure in the United States, responsible for around half of all cases. The danger multiplies when it's combined with alcohol or taken across multiple products without realizing the doses are stacking. To put that in context against other causes of sudden, severe liver failure in the U.S., acetaminophen accounts for roughly half of all cases, dwarfing any single other cause, which is a strong argument for checking labels carefully anytime you're combining pain or cold medications. Quick rundown on the three main viral hepatitis types, since they're spread and managed very differently. Hepatitis A spreads through contaminated food or water and almost always resolves completely on its own. Hepatitis B spreads through blood and body fluids and can become chronic, especially if acquired at birth. Hepatitis C also spreads through blood, frequently becomes chronic, but is now curable with modern antiviral medications in the large majority of cases. The pattern narrows your search, and fatty liver disease, alcohol, viral hepatitis, and medications, especially acetaminophen, cover the overwhelming majority of real-world cases. Here's the uncomfortable truth about this whole panel. Because your liver has so much reserve capacity, it's entirely possible to have significant, ongoing scarring and still see largely normal numbers on a standard blood test. Left unaddressed over years, the progression tends to move quietly through predictable stages: simple fat buildup, then inflammation, then scarring, called fibrosis, and in a meaningful minority of people, eventually cirrhosis, where scar tissue has permanently replaced healthy liver structure. Left completely untreated, this natural history typically unfolds over 10 to 20 years, though the pace varies enormously between individuals depending on genetics, weight, alcohol use, and diabetes control. The encouraging news is that this progression can be slowed, or even partly reversed, at almost every stage before advanced cirrhosis sets in. This is exactly why doctors increasingly reach for tools beyond the blood panel to check for scarring directly. a technique called elastography, essentially an ultrasound that measures liver stiffness, can flag significant scarring years before it would ever show up as an abnormal blood test. Given that blood tests alone can miss early disease, it's worth knowing which risk factors should prompt a more thorough look. Even with completely normal labs, carrying excess weight, type 2 diabetes or prediabetes, regular heavy alcohol use, a family history of liver disease, and any past exposure to hepatitis. And if you ever notice any of these signs, don't wait for your next scheduled physical. Persistent fatigue that doesn't improve with rest, unexplained abdominal swelling, easy bruising, or any yellowing of the skin or eyes. One more practical detail. If you ever do develop pain from your liver, it typically shows up in the upper right portion of your abdomen, just under your rib cage, sometimes radiating toward your right shoulder blade. Normal numbers on a standard panel are reassuring, but they aren't a guarantee, especially if you carry known risk factors. Reserve capacity is a gift, but it can also let real problems hide in plain sight. Let's bring everything together. Here are the 5 things worth remembering the next time you see this panel on a lab report. Here's a simple way to lock it in. Remember the word LIVER. Leaking enzymes are ALT and AST. Injury pattern versus blockage pattern is the key sort. Value of bilirubin tells you the location. Estimate true function from albumin and INR. And reserve capacity means normal doesn't always mean healthy. Quick check before we close. If ALP and GGT are both significantly elevated, but ALT and AST are only mildly up, which pattern does that suggest? It's worth being honest about what this panel can and can't tell you. It's a fast, cheap, widely available first look that reliably flags a real problem. What it can't do is name the exact cause on its own, or guarantee your liver is completely healthy just because the numbers look normal. If you take one action away from this video, let it be this short checklist. Know your own risk factors. Don't mix medications without checking labels. Ask your doctor to explain any abnormal result rather than just the number, and don't panic over a single mildly elevated value in isolation. One last myth worth retiring for good. Myth: a completely normal liver panel means your liver is definitely fine. Fact: given how much reserve capacity your liver has, and how many of these markers measure injury rather than function, a normal panel is reassuring but not an absolute guarantee, especially if you carry real risk factors. So, in plain terms, one last time. Liver function tests are a blood panel that mostly checks for signs of liver cell damage and bile flow problems, plus a couple of true measurements of what your liver actually produces. Together, they give your doctor a fast, useful first snapshot, not a final verdict. Your liver works quietly in the background every single day. This panel is simply a way of checking in on it, not a final verdict, but a useful, first snapshot worth paying attention to. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.